item before I introduce Amy. And that's yesterday, the county board passed a resolution about vaccinations, COVID vaccinations and testing. Some of us may have some strong feelings about that, but this is an informational meeting. We asked Amy to talk about COVID in Madison County and perhaps what's happening around the country and other services that the health department provides. So I would like to keep it focused on those issues. If Amy wants to comment about the resolution, that's up to her, but let's try to keep focused on the services of the health department and the latest information about COVID. So Amy, we're very happy that you're sharing your vacation time with us. Thank you. Amy Yeager is the Public Information Officer for the Madison County Department of Public Health. So Amy, how do you want to run the meeting? Do you want people to hold their questions until you finish?
Yes, because I actually, from a couple of those emails, it sounded like you wanted the history and the structure of the department. And I think it's best to start there. And I think for this particular group, you know, a League of Women Voters to me would be very interested in how we got a health department in Madison County, how it's structured, how it's ran. And I think all of that is important for you to know. I know you're a very active group in the county. I'm familiar with some of the work you've done over the years. So, when those questions came through, like what's our affiliation with the county board, what are the, how do we get funded, things like that, it's easier for me to do my normal spiel of the history of the department, the structure of the department, those kind of basic things. What's Public Health 101? What are our current programs and services? And then COVID kind of comes along at the end of all of that. And then one of the guests tonight is Becca Chaucy, and she is our data and education specialist at Madison County Health Department. I asked her to join tonight for a few reasons. First of all, I wanted her to join because it's her and I are the only ones on our team. We are the community health division currently at the health department. And two, she is the one that's been the primary person responsible for tracking and doing all of our data dashboard, our hub. She not only does all the data for all of that, she did all of the computer side on the back side. So she created all the programs and she creates all the mapping and everything that's out there. So she's going to be the one to kind of look at some of those numbers a lot faster than me because her spreadsheets are way bigger than mine.
Okay. And before you get started, Amy, people that I see already have their microphones muted, but if you are not muted, please mute until you want to ask a question or make a comment.
So what I was thinking is I can probably do all this in a half hour or less, and then people have time to still ask questions because I know you had a lot of questions. But and honestly, all I have written down are some bullet points because do you know how many times I've said this to people over the years? But I think it's important to know, and it helps to put it in context. And since I know that you all are interested in what's going on and how it's going on and who is responsible for what, I thought you need to start at the beginning and to know how we're even here to start with. So the other reason I asked Becca to come on is because she's only been with our department about 2 years, and it's been through the whole pandemic. So she hasn't even got to hear me do the history of the department or anything. So instead of me saying it all to her and to you, I figured I could kill two birds with one stone tonight by having her jump on. And she's already done a full day of work and the Madison County Youth Board meeting tonight. So she's going to be ready to be done when we're done. I, on the other hand, am on vacation and spent all day with my grandma. Okay, so we'll go ahead and get started. My name is Amy Yeager. I'm actually the Director of Community Health at the Madison County Health Department. Public Information Officer is one of the 8 areas of responsibility that I have at the department. And I've been there for 21 years. So I'm very well versed in all of this. I'm the only person that's had this position. I got to create it and make it what it is, with some things along the way that we didn't anticipate. So just wanted to give you a little bit of, like I said, Public Health 101 and history of public health here in Madison County. So for one of our big anniversaries, like I think our 10-year anniversary of the health department, we found articles way back to the 1940s, if not earlier, of attempts to get a public health department in Madison County, Illinois. We did not get a public health department in Madison County, Illinois till 1996. And that was from a group of dedicated, diligent community partners that worked in public health at agencies and just couldn't stand that we still didn't have a public health department. So in the early 90s, they started working together to try to get a public health department, find out what all that would take. We ended up having a Hep A outbreak here in the St. Louis region in the early 90s. And so that group went to the county board and said, you probably need to see about getting a public health department, because there was a lot of Hep A outbreaks going on in the region, and nobody's inspecting our restaurants in the county. No one's keeping an eye on that. And they were like, we didn't know that. So in 1994, the Madison County Board passed a resolution because it had been put to vote of the people again, after several times of being put to vote of the people over the years, and they had voted it down again. So the county board had the ability at that time to just make a resolution on their own. And so in 1994, they passed a resolution. This information, a lot of it's on our website, as far as the resolution numbers and stuff like that, to create the Madison County Health Department. And there were some steps they had to take to do so. One of the decisions that they had to make, and this answers one of your questions that came through in advance, is there are two ways that you can have a board of health in the United States that's connected to a health department, because each health department has to have a board of health. Your board of health can either be a group of independently appointed people, or which includes at least one physician, one nurse, and one dentist. So it has to be at least 5 people with those 3. Or it can be your board of elected officials, which in our county, we call them county board members. Other places call them county commissioners. There's all different names for them. They're all the same thing. However, if you choose to have your elected officials as your board of health, then they also are required to have a health advisory committee to guide them, because almost always elected officials have no experience in public health at all. So if that's the case, then they have to have at least a 5-member health advisory committee with a physician, a dentist, a nurse, and 2 at-large people with what's called a fitness for public health. So the Madison County Board in 1994 decided they wanted to be the Board of Health. In the state of Illinois, we have 102 counties, and only 2 counties, their Board of Health is their county board of elected officials. It's us and Kane County are the only 2 set up like this. And nationally, it's a rare way to have your county board as your Board of Health. So we're in a unique position with that. And sometimes it's advantageous and sometimes it's not. But with that being said, with all my years in the field, I've heard from people who are set up the other way, that the more traditional way, and they have some advantages that way and some not. And they usually are the opposite of what we have. So neither way is right or wrong. They're just different. And you have to understand how everything operates and how that association happens. So the only way that they could do that, though, was by permission of the Illinois Department of Public Health, who has the power from the Illinois state legislature to give authority to an agency to be that public health authority in the county. So Madison County Health Department is only open for operation, not because of the county, but because of the Illinois Department of Public Health. There are certain criteria that we have to meet, and there's a state statute that we have to meet in order to remain the authority for public health for this county, with all of the rights and responsibilities that go along with it. As part of that, we're required to have a county board. Our county board by resolution currently is our health board is our county board. They are only the Board of Health by the authority of the Illinois Department of Public Health which is given the ability to do that by the state legislature. I've explained this to some of our politicians, and I'm not going to lie, some of them really struggle to understand this. Like, you are not solely in charge. This is not your rodeo. They think it is. Some of them think it is, but it's not. And some of it's just a learning curve because we've got a lot of new people. I've never seen so many new people in Madison County offices as we've had in the last 5 years. So we've tried to educate them along the way that as a public health department, we're required to follow the Illinois Department of Public Health regulations and the CDC regulations because we are a public health entity given the rights and responsibilities to do so by Illinois Department of Public Health, by the authority of the Illinois legislature. Has nothing to do with the county board. Does that make sense? And we're required by law to follow IDPH and the CDC. So the county board, like the resolution last night, we have no comment on that. As a county board, they can do whatever they want. And as a board of health, there's some stuff they can do and there's some stuff they can't, because there's certain regulations that we have to follow regardless of whether the county board agrees with them or likes them. It doesn't matter. Just like a hospital president may or may not always like some of the healthcare rules, but they still have to follow all of the CMS and health and hospital rules because that's their line of regulation. And our line of regulation is IDPH and CDC. Does that make sense? Okay. Where the county board more regulates is our employee base, because we're all employees of the county government. So, you know, we've got mostly union employees at the health department, just like the whole county does. So all of that kind of stuff, absolutely. But with some of the public health stuff, they're not public health officials. Even the health advisory committee that we have, which ours is a 10-person health advisory committee, our original resolution that was written in 1994 and passed in 1996, because it took 2 years to get it through and approved by IDPH and the state legislature. So our official anniversary date is June 3rd, 1996. We have a 10-person health advisory committee with at minimum 1 physician, 1 nurse, 1 dentist, and then the other 7 are supposed to be or have to be someone with a fitness for public health, meaning that they have the knowledge and experience professionally in public health to serve and guide the county board on health decisions. That's always been a little bit of a weird relationship on how all that's going to work and supposed to work ever since I started. Sometimes it works really well. Sometimes it doesn't. Sometimes the communication's great. Sometimes it's not. I think it just kind of depends on what's going on and who's in charge, because there's a chair of the health advisory committee, there's a chair of the health department committee, and sometimes they think to communicate with each other and sometimes they don't. It just kind of depends on who it is. So our county public health director, Tony Corona, she's kind of the glue that keeps all that together and reminds them, hey, you might want to talk to this person about that kind of thing. So she's really our glue that holds that whole piece together. So even though she can't tell any of them what to do, she may say, hey, you might want to have some folks. She tries to have health department committee members and health advisory committee members go to the opposite meetings, just so they can give reports to each other and have even more of a chance to talk. She can't make them do it, but she often encourages it. And there's usually at least 1 or 2 health advisory committee members at a health department committee meeting to discuss that. So she tries to keep that all moving, and it just kind of depends on what's going on. Honestly, a lot of the times before COVID, it was a lot of just boring regular business. Us directors would give out reports on what was going on with our divisions, something exciting or an issue that came up, or filling them in on this or that. As far as health department committee, which the county chairman selects usually about 5 to 7 county board members to serve on what's called the health department committee, just like he has a legislative committee and a grants committee and all those other committees. And those folks oversee the health department on a monthly basis. So they're the ones that meet the first Friday of every month. They sign the bills, they get a report from Tony, We used to do director's reports, but then the meetings would be really long and they didn't want the meetings so long. They said, you know, probably 10 years ago, they were like, we trust them. We know they know what they're doing. If there's something you want to highlight. So every once in a while, one of us will go and highlight something that's going on. Like me or the nursing director during COVID, or I'll come and I'm usually the one that'll show up, or Scott, our financial guy will show up like at budget time to explain some of the things that we're doing in the budget. So usually they were pretty boring meetings for the most part, but during COVID, they've been pretty heated with a lot of questions and a lot of discussion, as they should be, because this has been very different for all of us on a regular life basis, let alone in a public service basis, as far as us and our employees, or an elected official basis, because we're all in this, but we're all in different seats in it. And lots of people have lots of questions. And so it's been good to try to keep that communication open. And Tony's done a fabulous job with how she's ran this response, how she's kept them all super informed. At the very beginning of the response, we had a director's meeting or a department head meeting, and she called together every department head of every county ran department. And we had them all on our emergency operations center. Just pretty much, she just laid it out to them. This is what it is. This is what's coming down. This is what it's happening. Here's how it's going to affect you. Here's what we need you to do. Here's how we need you to do it. And this is, we just need everybody to step up and do it. And I've had several department heads tell me that before that meeting, they were like, yeah, this might be something. And after that meeting, they were like, oh crap, health department's not playing. This is going to be something big. And one of them just told me this again last week. And I'm like, yeah, we weren't playing. Public health people don't cry wolf, because when we say something big's happening, we need people to believe us. So we don't overblow things. So we've had a lot of support from the county departments through all of this, and that's been helpful. So that's a little bit of the history of our health department. So we started officially June 3rd, 1996. We had a nursing division and we had an environmental health division. Tony was actually originally the environmental health manager. And we had an original nursing manager who was a retired nursing director or nursing teacher from SAUE. And then from there, we've had a few since then. The department's grown over the years. In 2000, we added what was called then a health promotion division. It's now called community health, the community health division. I was hired to create and run that division, and I've been the only person to lead that division and have this position. On September 1st, 2001, myself, and Tony, and our then nursing director, her name was Deb Cheshlock, if any of you know her, she was a retired Navy officer. The three of us stood on the back porch of our original building, which was the old TB clinic in Edwardsville, if you're familiar with it. It's now about the parking lot between Stugo's and Buffalo Wild Wings was where our building was. When the three of us stood on the back porch that day, saw the sky and said, well, girls, public health just changed today. So on that day, public health went from a seat at the little kids table to a seat at the big kids table. And ever since then, we've been front and center with emergency response and emergency preparedness. Our department has always taken it very seriously. We do, well, we have required exercises and trainings every year, and we probably exceed those by several a year. Personally, I usually end up doing about 4 exercises and 3 or 4 trainings a year in non-COVID times. So we were well prepared. It's just when something as large as it being global, and then you factor in it's a new virus, that knocks the socks off. Like that was, and then on top of that, in the middle of a very contentious election season, both locally, statewide, and nationally in this country, that was like the trifecta of dumpster fire for public health. I don't know another polite way to put it, but that's pretty much what that was. So over the years, we've been able to build all of those divisions in, and that's been helpful because we've got a really strong infrastructure of public health at our department. We are a small department, so our county has about 265,000 residents. And at the beginning of the pandemic, we had 37 employees, 3 of which were part-time. We were able to hire about 30 contact tracers, which now we're down to about 9 contact tracers. So we have about 46 employees for 265,000 residents, and we're trying to run as many of our regular programs as we can and still do a thorough job of responding to the pandemic. And it's a huge challenge, but we're doing the best we can with what we have and what we can do. During the height of the initial part of the pandemic, we had a lot of support from, we have an MRC, a Medical Reserve Corps. We have 610 members currently in it. We got a lot of volunteers through there. We were particular though about who, especially toward the beginning, we were letting come in. A lot of our older volunteers, we asked them to do things that they could do remotely from home. So things like helping us monitor the media or things like that, because we didn't want to subject them to the virus that we still didn't know much at all about, but it was obviously affecting the elderly and the older populations a lot more. So we didn't want them out and about at testing sites and things like that. And then once we learned more, we were able to bring them more into an active role in the response. We also had the support of the Illinois National Guard, especially at our mass vaccination site, that we ran 7 days a week for 8 months at the Gateway Convention Center. And we averaged, I don't know what we averaged, but I know there were many days in those 8 months, many months of those 8 months that we had anywhere from 2,500 to 3,000 people every single day going through that mass vaccination site, 7 days a week. Those of us on the leadership team worked 7 days a week, anywhere from 12 to 15, 17-hour days from February 23rd of 2020 through the middle of June 2021, till we finally decided we needed to step back and not work so many weekends and try to get a little bit of sleep once in a while. So as far as how the health department is structured, Tony Corona is our director of the whole department. And then she has 4 division directors under that. So Erin Baster is our health protection director. She's been with our department for a while. She was an inspector and then a sanitarian, and now she's the director of that department. Amanda Pruitt is our nursing director, and she was one of our clinic nurses. Then she was our communicable disease nurse. Then she was our communicable disease coordinator, and now she's the director of the department. And then Scott Purcell is our I think his title is actually administrative division director. He's our fiscal guy. He's the guy that takes care of the money and the paperwork and all of the kind of operational business side of the house. Him and his staff are the ones that do that. And then myself over the community health division. So from there, we have various staff. The emergency response division used to be its own division, but after its director retired, Tony reorganized and took our environmental health division and made it a health protection division and moved in, emergency response under health protection. So that's where it is. Our emergency response coordinator is Michelle Milton, and she does an amazing job. She has an undergraduate degree in microbiology, I think it is, because she was going to go into pharmacology, but then she found biosecurity and fell in love with it. So her master's is in biosecurity from St. Louis University. So she's very well trained in what she does as well. And she's just amazing what she, handles. That division alone is huge for only 2 people being in it. And we have like 5 different sets of funding that comes through there and all kinds of plans that have to be done and exercises and trainings and requirements for all of them. And Michelle does an amazing job of keeping up with all of that and making sure we're all up to date and up to speed, plus still trying to lead the pandemic response for us. How we're funded as a health departments are all funded differently, but in the state of Illinois, we used to have an old state tax that was called a TB tax. So it was a local tax that was done by state law. I don't know if any of you guys know any of this or not, but so when we became a health department, so in Illinois, as Illinois health departments either were formed or as TB became more under control, local health departments could petition the state legislature and request to turn the TB tax into a public health tax for that voting district, for that jurisdiction. So when we were formed whenever they started the process in 1994, like I said, it was a 2-year process. First resolution was, I think, March of 94. We became official June of 96. So during that period, one of the things that had to happen in order to become a health department was to find initial funding, and that startup funding was a request to the state legislature to turn the TB tax that the county had been collecting for the TB clinic to convert it to a public health tax. So that's a special fund. It's a special tax fund. If you're familiar with how the county budget's set up, the health department does not receive one dime of the general revenue funds from the county government, not one dime. So when people talk about that, we don't get that. All we get is a special tax fund. That's the old TB tax. There's a scale that's in mills, and there's an allowable scale that the state of Illinois gives with what a county can assess for taxes for public health through that old TB tax, new public health tax. We are still at the absolute lowest mill possible, and we've been at that same amount since 1996 when we were formed. We've never had an increase. And so on a $5,000 tax bill in Madison County, about $12 of that $5,000 goes to your public health department. So when people say, well, we pay your salary, and I listen, I'm like, okay, well, you probably just spent your 12 bucks. But you don't do that, but you're thinking it because they're like, I'm like, you have no idea. Because most people don't know how we're structured and how we're paid. And I think it's important for people to know that. But we take being public servants very seriously, because about 1/3 of our income comes from that public health tax. About 1/3 of our income comes from various grants. So again, a lot of grants, not all of them we have, but a lot of them are tax dollars because we get a lot of grants from the state and federal government. So since we get a lot through the Illinois Department of Public Health primarily, or from the federal government, or the state gets federal money that then they match and that we can write for those grants, those are all tax dollars too. So when you add that in, it adds up a lot quicker as to what is probably coming out of people's pocket. I just don't think most people realize that we don't get any general revenue money at all from the county government. So then the other third, so the first third is that county health tax, the public health tax. The second third is the grants that we write. Our different division managers usually write the ones from the state because they're kind of a fill in the blank, turn it in and you get the money to do the program kind of thing. If it's a competitive grant, I'm usually the one that writes it. So if it's one where only a couple recipients are going to get it, or it's a national application or even a state one, like right now we're waiting to hear if we get this opioid infrastructure building grant, and it's CDC money that's coming through the state. The state didn't even have to match it. They just have to follow the CDC criteria. We qualified for it. I wrote for it, and we're just waiting. We anticipate that we're probably going to get it because they've only asked us one question about it. And it was a pretty easy question. So hopefully we're going to get that. And Becca's going to be working on that quite extensively if we get it, to help build some of the opioid data infrastructure that we need in the county. We've already been doing a lot of programming on it. And this is a piece that we've all known we were missing. And this would be a great opportunity to be able to expand and get some more information that we need there. So that's where that second third comes from. The third comes from what's called fees for service. So we charge fees for service for various things. For instance, most of the fees for service come from restaurants, from restaurant openings, restaurant closings, the permitting, temporary event permitting. A lot of our fees for service come from that particular service line. We also do fees for service in nursing. So there's certain things that we may be able to charge a fee for or recoup a fee for in nursing. Believe me, we're not making money. It's public health. You know, if we're allowed to charge a $7 administrative fee on a vaccine shot of some kind, like the flu shot or a kid's vaccine or something, then that's all the more we're going to get, no matter how much it takes, how many people it takes to file the paperwork, administer the shots, supplies. You know, that all isn't $7, but if that's all we get reimbursed for, we at least take that much to try to help offset the cost. So then we have to derive more of it from either the fees for service or out of that tax dollars, or if it's a program like Vaccines for Children is a program and we have a grant for that. So that helps offset the cost of vaccines, especially for kids from a lower income kind of bracket, to be able to make sure that they're taken care of. So that's how we're funded. I know that was another question that came up. The sole purpose of public health is to serve the community and protect the public's health. That's our sole mission. public health is apolitical. Politicians and politics do all kinds of stuff to public health, with public health, about public health. But for us as a field, we are apolitical. We have the mission of protecting everybody's health, whether they want to be protected or not. So we can provide all of the skills, opportunities, and information, but in the end, the public has to do their role in public health as well and apply those skills, opportunities, or information in order to create the full impact. Like, I can't get someone to decrease their risk of developing cardiovascular disease myself. I can do it for myself, but I can't make Rebecca, because she's the first one I see on the screen, I can't make her do it. I can give her those skills, opportunities, and information, but then Rebecca, as a community member, has to figure out what she wants to do with all of those, to engage in that, to also impact our collective cardiovascular risk in the county, not just for her as an individual, but for us as a county and for the public. So that's the role of public health, is to serve and protect the public's health. We know we're not going to save everybody. We never think that we do. In our emergency response plans, we even have to think about what percentage of loss are we willing to bear. Because in some instances, like an anthrax attack, we're going to bear a big loss. And what can we do in advance to try to prepare and prevent that as much as possible to minimize the loss that we know is going to happen? And that's what we've tried to do with COVID as well. What can we do to minimize the loss? That was the point of the vaccine. We've known from the beginning, and it's been said from the beginning, that the vaccine isn't meant to prevent you from getting COVID. Not at this point. We don't know enough about the virus yet to do that. We've got a lot more to learn about the virus before we can develop a vaccine to do that. The vaccine was originally designed to decrease your severity of illness, your chances of hospitalization, and your chances of death. So again, that's our field, public health, trying to decrease that loss that we're going to bear because of a certain disease or illness that's out there. And so we do that all the time in any aspect of what we do. So in Public Health 101, I'm going to do a quick, what I call the triangle. So the very core of public health is what's called the 3 core functions. We have the 3 core functions are assessment, policy development, and assurance. And so honestly, over all these years, when Tony and I sit down to plan things, because I'm over all of our community assessments, all of our internal things like that, all of those community relationships, that what direction do we need to go? Who do we need to collectively pull together to create an impact? So when her and I sit down and say, where are we at? What does it look like? Where are we going to go next? Or if someone comes to us and says, can you do this program? Can you pick up this? Can you take care of this problem? The lens that her and I either collectively or individually take it through first and foremost is always that core public health lens. Is this assessment, policy development, or assurance? Because if it's not one of those 3, it's important, but it's not for us to lead because it's not public health. So public health is not required to be everything. We're required to lead things. So just like right now, we don't have to be the ones doing COVID testing, but we have to assure that COVID testing is available to our citizens as readily as necessary within the resources available and communicate that to them. So that's the role. So when people are like, why aren't you doing more testing? Because we've assessed and we have as much testing available right now as possible with the resources at hand. And we actively communicate where that is. Becca maintains it on the hub all the time, and we've got it on the website. We've put it out through social media. You can text the vaccines thing and it'll pop up. So we've got it out there. So that's that assurance piece. So those are our 3 core things that public health does: assessment, policy development, and assurance. Then after that, there's what's called the 10 essential services of public health, and you can Google them. I'm not going to read them over to you, but there's 10 essential services that takes those top 3 and kind of makes them a little more specific so that you can see there are things like research and surveillance and monitoring, those kind of activities that we do to enact assessment, policy development, assurance. From there, then about almost 15 years ago now, probably 13, they developed what's called the Public Health Accreditation Board. It's a national board, and it's a national set of domains for public health. It's voluntary public health accreditation. And so although we've not gone for public health accreditation yet because it's expensive, they are going to tie funding to it, and they've already started doing that. We have been building the pieces of it, those domains, at our department over the last several years. Part of the domains is actually a requirement in Illinois and has been since 1996, long before this came about, and that's called IPLAN, the Illinois Process for Assessment of Local Needs, Illinois Process for Local Assessment of Needs, IPLAN. In that, each health department in Illinois every 5 years is required by state statute to conduct a thorough countywide needs assessment of qualitative and quantitative data, identify at least 3 health priorities to be addressed collectively by the community over the next 5 years, and then lead the development and implementation of a plan to impact those identified health issues. And you have to have a high level of community engagement in the process. There's a bunch of other details too, but that's the gist of it. And that's how we remain a local health department. So every 5 years, we have to do this process. We have to lead it, not be it. We've got amazing community partners in the county that have been very involved in this from the beginning. And they actually do this. We have coalitions that work on those health priority areas and that plan that they help write over that next 5-year period to try to impact it. We're not going to solve the big ones. I mean, the big ones are going to change. We're not done with it this time, but I don't anticipate, neither does Tony anticipate, neither does Becca anticipate that they're really going to change. Cardiovascular disease, mental health, and substance abuse. But we call cardiovascular disease obesity in this county because we're trying to look at the preventative aspect. What is probably driving it? And obesity was overwhelmingly what was driving our cardiovascular rates in this county, and substance abuse. So obesity, substance abuse, and mental health are our 3 big ones in this county. And our groups just try their best to work at a collective impact on a piece of each of those problems because our rates are so bad. It's going to take us all a long time and a lot of work as organizations as well as individuals to get some of that under control. So along with iPlan comes what's called the Local Health Protection Grant, which is one of our largest grants. That and our Emergency Response Grant are the by far two largest grants that we receive at the health department. And the Local Health Protection Grant, you only get that if you're a certified local health department in Illinois. So we are given the authority. They give us money to conduct the core programs, the water program, the communicable disease programs in our county. Those are primarily linked to that. So community health does the iPlan and all of that work on the plan during the 5 years. And then the money goes to fund some of those other core programs in public health, just because the state's never updated what the money goes toward. But it's a huge chunk of money that helps fund the health department. And it's also what continues to give us the authority to be the health department. So then those division directors are responsible for those programs and getting their reports in on time throughout those 5 years as well, or that would impact our ability to still be the local health authority. So a lot of our core programs now can be found on our website. I know it needs to be updated again, and I'm so sorry, but we've been a little busy with responding to COVID, so we're behind on doing some of that updating. But you know, in nursing, we don't just do immunizations, we do all kinds of other things. They'll do international travel consult. Like if you're going to go to Haiti in June, you can call the health department and the nurses will do some research to find out, you know, what are the primary diseases in Haiti in June and what kind of shots do you need to protect yourself and what's the schedule you need to get them on before you go, kind of thing. We also have a lead program that we work closely with the community development department. They do all the lead inspections and abatement with residents, and we do the lead testing and genetic stuff with the children that are in those particular homes. We have a hearing and vision program. We provide hearing and vision services. That's a grant that we have to most of the daycares and the pre-Ks in the county to get kids started off on the right foot by being able to see and hear before they even step into a full classroom in kindergarten. It really helps with academics and learning as well as overall health to catch that at a young age. And we've been doing it a long time, and it's amazing how much we catch. and how much that really does help people and impact them. We have the breast and cervical cancer program, which is federal and state funded to help women that need screenings and diagnostics. And if you go through the program and you're found to have cancer, then the Illinois Cancer Act will pay for all of your treatment. And then we've had the Komen grant before, and we can still access it. I think we have a small Komen grant still when we need it, like if a woman needs a wig or if someone needs transportation to doctor's appointments, things like that. We have a lot of funding to try to help offset that. Plus, by keeping a little loose money for Komen, the state will only pay for women, but men get breast cancer too. And in any given year, we can have anywhere from 2 to 5 men diagnosed with breast cancer that come through our program. And we offset that with dollars from the Komen grant or other funding that we find to help pay for that, because we don't want those men to be left out just because of their, just because of their gender, and not be able to get the help if they don't have the insurance to help offset the cost of the diagnosis and the treatment, things like that. So we have a lot of other nursing programs, but those are some of the real key ones. Our emergency response division, like I said, we participate in a lot of coalitions here in the bi-state. We do a lot of planning in the bi-state, both for public information and for preparedness. All of us on leadership teams serve on some kind of committees in the bi-state in some capacity to continue to plan for different kinds of emergencies and work together. Becca was on our call just yesterday. We have a public information system among the 18 county health departments in the bi-state where we meet every other week by phone right now to coordinate messaging and keep each other up to date and how we're handling things in our different counties across the bi-state for the response. And we have our own communication plan should we need to do something jointly. So there's always a lot of stuff going on. Our the other health protection, the environmental health side of the health protection division, we do all those restaurant inspections and temporary events, but they also do well inspections and the opening and closing of wells. They do the opening and closing of food establishments. We have a West Nile virus program that's very active that we're diligent about. We started doing a little bit of tick surveillance right before the pandemic, but we've had to kind of suspend that lately. We do radon and radon sourcing kind of things. And there's some other programs as well, but those are some of the key ones. We do some work here with the waterways in the metro area. And then in our division, community health does a whole lot of stuff, but we do a lot of concentration with those health priority areas. Obviously, for emergency response, COVID's been our main focus for the last 2 years. There's 3 of us that really started working on this in November of 19 because we saw what was going on in Asia. Because again, Michelle Milton is very, very good. Our emergency response coordinator, she's still like a microbug nerd and follows all that stuff. And she saw what was happening and she started pulling out our plans, talking to us. She wasn't here when we did H1N1. So she started talking to those of us that were here for H1N1 as to how we did things. I came back from visiting family at Thanksgiving and she was like, okay, we need to get this ready. We need to get this. Like she was fully anticipating something coming well before it really burst out open. So we were ahead of the game thanks to Michelle from the very beginning for our response here in the county. We weren't playing around. We knew it was going to be big and we tried our best to do what we could ahead of time with the little information that we had. So COVID's been up and down, as you know, and I'm going to let Becca talk about some of the numbers if that's what you're interested in, and then I'm going to stop and have some time for questions. Hopefully this was at least somewhat helpful. So Becca, if you have some of those kind of latest numbers or interesting numbers or whatever I'm out of it because I've been gone for a couple of days, so I'm not sure where we are with things. And Becca's always like, literally every 10 minutes, hey, I was just looking at this. Let me tell you what this did. I'm like, okay, cool. Because you always need young people around who have new, fresh ideas, a new set of eyes, and are super smart. My first boss was Jean Schramm. If you guys know Jean Schramm, she was the director of prevention at Chestnut Health Systems for a long time, and she lives in Troy. She always told me, hire people who are as smart as you or smarter than you, and then get out of their way and let them do their job. And I couldn't have made it through this response without Becca. She has just brought a whole different element to this that we knew we needed, but none of us knew how to do it. And she was like, oh yeah, you just do this and this and this. And I'm like, cool, go do it. Sounds great. So, and Jean, my first boss, always says that Becca was me 20 years ago. And then she laughs. She's like, see, it's like a daughter having a daughter. Good luck. So she likes that I have a Becca, and I do too. All right. You want to take it, Becca?
Yeah. So first off, can you guys hear me? So my name is Becca. I am the data and education specialist and backup public information officer. I crunch data. You know, I have all the COVID data. I also do geographic information systems, which is mapping and everything. Sorry if my cat comes into view. He's needy. I'm at home right now, so my cats are yeah. Anyway, so I don't know if any of you guys have seen the dashboard or anything like that. Have any of you guys seen it? Yeah, okay. So I'm gonna share my screen if that's okay. Let's see if it'll let me. Okay. So here is the dashboard. I actually just updated it a few hours ago. So I'm gonna walk you through that because I don't have my other data ready for me right now. It's on my other computer and I'm on my desktop right now. So today, actually, we reported 897 new cases today. And we had 3,270 people tested. As this is like within a 24-hour period. We had 3 deaths within the past 24 hours too. And then we had 920 people released from isolation. So over here in this section here, these are all of our cases in individuals 19 years and younger. So this is the past 48 hours. And so you could see on the 19th, we've had a little bit over 250 new cases under 19. And then on the 20th today, we had close to 300 new cases in people under 19. So that's a lot of children, in my opinion. In this section over here, this is our age breakdown in the past 48 hours. This is everyone. So you can also, in case any of you guys didn't know this, you can click on these circles here and you could deselect and select age groups. So if any of you guys are interested in breaking it down a little bit more, that's one way you can do it. So if you want to look at a specific age group, you can deselect all of these and you'll be able to see them. So
Becca, you can do that. You can do that with all those circles on the website or on the dashboard, right?
Yes.
Yeah.
I made it so you can. So down here you have your case rate. And so this kind of shows what the transmission is like right now. So I want to say, and correct me if I'm wrong, Amy, your case rate is supposed to be under 100 per 100,000 people. So this is 2,100.
Really wanted under 50.
Under 50.
To be considered
is
low or safe, it's supposed to be 50 cases per 100,000.
Thank you. I have all these numbers floating in my head. It's sometimes hard to keep them straight. So I have this like cheat sheet to keep track of all this stuff. But so this is 2,168 per 100,000 residents. So this is a population-based rate. On this right-hand side here, so this section here is all of our new cases by zip code. So this is in the past 24 hours. These are all the new cases in each zip code that we've reported. So you could scroll up and down and you'll be able to see it. To the right of that is our cumulative cases per zip code. And again, this is in totality throughout the whole pandemic, all the cases we've reported. So there are zip codes that are suppressed if they are under 5 cases, they are not reported here. So there may be zip codes that aren't being shown. They may have 0 cases, they may have 5 or less cases. And that's with the whole state with COVID right now. So this next tab, it shows us our confirmed cases by day. And this has on the left-hand side, the number of new cases we reported each day, and that is the orange line. And then the blue line is our 7-day rolling average of new cases. So 7-day rolling average kind of evens out the what you're seeing. So you could see you know, you had a couple high days. This was in November of 2020. You had a really high days, and then you had really low days. And so the blue will help even that out and make it so you can actually see a good epi curve. So our previous high before, you know, the Omicron and before Delta, you know, before we had this huge surge that we're in right now, in November of 2020, that was our previous high. So I think it was November 16th, we had November 16, 2020, we had 633 new cases in one day. And that was our previous high, previous record ever. As you could see on this far right side, we have exceeded that significantly. And so you can also, there's like the scroll bar at the top up here. You can also scroll it over to see like a more condensed view. So right now, looks like we're leveling out, possibly starting to come down. So that's a good sign if it keeps going down how it is. But cautiously optimistic. It could be just leveling off, but we're hoping for the best. And
we've been pretty good at predicting this and watching, and
yeah, cautiously optimistic that
it looks like it's going in the right direction. So we're excited.
Yeah. But so you can see how we're going down, and hopefully it stays that way. On this right-hand side over here, this chart, the green is our active cases. So these are all of the people that are in isolation right now. They have not been released from isolation, and they are a positive case. And this blue is our active close contact. So these are all the people that have been in close contact to someone who has been sick. So if I have COVID and I just saw Amy would be considered a close contact of mine. And so she would be in that blue line. And so you can see our active caseload is going down. So that's good that, you know, these two blue and green lines are all people that we're keeping track of and we're trying to contact or just keep tabs on.
And I'm going to add just a quick commentary in there. So if you notice, you might wonder, why is that blue line nowhere close to being matching the green line? Because it should have, right? And it's not matching for a few reasons. One is because this surge, and for those of you that are math nerds like Becca and I are, you can see how steep that slope is there on the orange and blue chart. And that slope was so steep, and I'm back to, we have 9 contact tracers. We have absolutely no way to keep up with all of the possible close contacts. Our contact tracers also contact all these cases, our nurses and our close contacts. They were having trouble getting to all the cases in a timely manner. They had no way to get to the close contacts. That's one thing. The second thing is the state has now put in a surge center, but it just started last week. And the surge center is an overflow for close contacts. So as we get cases in, we're going to handle close contacts for people that are 65 and older and that are part of outbreaks, like outbreaks at schools, outbreaks in nursing homes, you know, outbreaks at emergency response places like a fire department. Those kind of things we're going to handle, but all the other cases, their close contacts are going to be handled by the state surge center, so that hopefully this doesn't happen again should we have another surge. So that's why that number is so low. So that means there's a whole lot of people who were close contacts who got missed. The also thing is, all of our numbers only include those people that had tests that were ran in a facility that could report it to the state. So if you do a home test, you know, so if you get a whether it's the PCR, the antigen from like Walgreens or urgent care or whatever, all those get reported to the state or reported to us. The whole system, we all get access to the same data, the same results. If you did a home test, they're not in any of these at all. Missouri's piloting a few ways to maybe track home tests. Illinois is not. So none of this reflects at all any of those people who are taking home tests right now and getting positives. So the numbers look high, but they're actually lower than what they probably really are. So I just wanted to note that on here. And we're not going to go through all of the slides and stuff, but there's a few key ones that people seem to find interesting, and it's easier if Becca just kind of highlights it. But I know that that looks weird, and it's good to note, but there's no way to actually put it on there to tell people why it looks different there.
All right. Let me get this out of the way. Okay. So on this left-hand side, these are our cases by age group in the past 31 days. So this accounts for a little bit of December, and then all of January so far. So in the first 20 days of January, we've had almost 15,000 new cases. That's a lot of cases in less than a month. So on the right-hand side, these are all of our cases by age group in the past 7 days. So if you want to compare between, age groups in the past 7 days, you can go and get a visual of that and see what that looks like. The next tab is our under 20. So these are 19 and younger. This is on the left-hand side past 31 days. So you could see how we've increased in individuals under 20 that have had COVID. On the right-hand side over here, this is a comparison in the past 7 days. Here's our case positivity. So you can see we're kind of leveling out a little bit for case positivity. But there's a couple reasons that may be happening between maybe there aren't as many people testing, like in schools, because schools have been kind of out, or there's a couple reasons. And so this is why we have a lot of data points that we look at once to get a more clear picture between cases and deaths and hospitalizations and positivity rates and case rates. So down here on the bottom right, this is our case rate by week. And so you could see how we went up a little bit in the early fall, and how we started going down, and then how we went back up. And so this is updated every week down here. Here's our age and gender breakdown. This is all cumulative, so it's throughout the whole pandemic if you just want to get a good breakdown of what we've been seeing in totality. So you could see over here how it curves, and so it's skewed younger. And so you could see that our 20s age category, that's where we've had the most cases so far throughout the whole pandemic. Now with the deaths over here, you could see how the deaths have skewed a little bit older, and you could see that in the 70s age group, that's where we've had most of our deaths. And so it looks like we've had more females getting COVID, or at least being reported with COVID, than males. So with all these factors combined, there may be behavioral factors of why people may go get tested, or may get COVID, whether that be the type of job they do, or there's a lot of factors that go into this. And so this is why we look at the data, so that way we can also look at the behaviors that people are doing, and maybe see if there's some connection between the two.
Well, and real quick, if you look, so the fact that the cases are skewed younger shows the susceptibility, and that makes sense because those folks are more in the community, more in the workforce, and that 20-something have to go to work. They don't have a lot of sick time yet, and a lot of them are in the service industry that everybody fought to keep open, but yet then they complain when they close, but those service workers, whether they're retail or food, continue to get sick. So the susceptibility is skewed more toward the younger, but the severity of the impact of the illness is skewed toward the older population. So those are things that we can tell by looking at data from our training that we've seen. So that, like Becca said, that helps us plan too. Where do we need interventions? What kind of messaging do we need for different audiences? That kind of stuff.
So here's a map of our full vaccination rates by zip code. You could see the list on the right-hand side. You can zoom in and you can zoom out. You can also click on your zip code and it'll give you a pop-up over here. You'll get the count and the population and the rate. So that's something, if you're ever curious, the darker the color, that means the more fully vaccinated they are. The lighter the color, that means the less fully vaccinated they are. So the lighter colors are places where IDPH and we will focus for mobile vaccinations. IDPH is really doing a lot of mobile vaccinations right now. So that's great that they're helping in communities also. So here's a really interesting tab that at least I think is interesting. So you could see on the left-hand side your deaths by age group by month. And again, you can also click on these circles and it'll deselect and select age groups. So you can get the age breakdown of deaths by each month. And so you could see how they've slightly changed. But what's really staggering, at least to me, whenever I found this out, is on the right-hand side. So on this chart on the right-hand side, you have confirmed cases in the orange and deaths in the blue. So you can deselect, let's say, cases, and you get the same, chart as the left-hand side, but just solid with the full numbers. So, for example, December of 2020, we had 120 deaths, and that was for the whole month. But this is what is staggering to me personally. So if you compare December 2020, so we had 6,421 cases in the whole month in December of 2020. That was our highest month of cases ever throughout the whole pandemic. And November of 2020, we had 6,417. This past December, we had 6,289. So remember December of 2020, we had 6,421 new cases. But if we go back to, make sure I'm in the right, go back here. And this is our, I think, third tab. Just in the first 20 days of January, we've had almost 15,000 new cases in just January alone, and we're not even done with the month. But our previous high for a whole month was December of 2020, and that was 6,400. Well, 6,400. Sorry, just trying to get my numbers straight. So that's a lot of cases that we've had in January so far, when we've never seen this many cases at one time throughout the whole pandemic. So that's something that I look at frequently, and these tabs get updated every month. But I want to go back to the left-hand side real quick. So this left-hand side gets updated automatically whenever I personally update the dashboard, because every age group that I put in to update the dashboard automatically gets put into this left-hand chart. So you could see here's January right here. We've already exceeded last December, as in December of 2021, for new deaths so far. So we're what, about sixth in most deaths in a month. So that's where we're at so far, it looks like. So we may see more deaths, because deaths are a lagging indicator. So you see all your cases, and after your cases start going down a little bit, that's when you start seeing your deaths. So we may see more deaths. We may not. Hopefully we don't. But that's what we have right now. But whenever January is over with, I will go in on February 1st or February 2nd, and I will update this right-hand chart here, and I'll put in all the new cases we've had for the month and all the new deaths we have had for the month too. Here's a race.
The last note on that is, this was something I put in the paper last week when I did a radio and TV thing, is Becca showed you how high the cases were for December of 2020 and how high the deaths were for December of 2020. And the cases for January of 2022 are going to be at least 3 times higher than that December of 2020. But look how small the deaths are this month in comparison to a month where it was going to be a lot less cases, even though it was our highest number of cases. That to us is also an indicator of the effectiveness of the vaccine. because most of the people passing away are unvaccinated. So it's decreased the number of people who are dying from COVID because they were vaccinated. So it's decreased their chance of actually dying from it. So those are just some of those factors. When people say public health, well, how do you know? Well, we're trained to know what to look for and what it means and what to do. And that's one of those indicators that Becca and I've looked at throughout January is, wow, these cases are crazy, but the deaths are not. And some of that is the kind of variant that we have, but most of our variant right now is 2/3 of it's Delta, not Omicron. Even though Omicron's much more susceptible or spreadable, the fact that the deaths are staying relatively low when you look at the ratio of deaths per cases, it's much lower than it was in December 2020. And now you see that we've got, and we didn't have the vaccine then. We had a handful of healthcare providers who had got the vaccine by the end of December 2020, and that was it. So that's made a difference for us to see that that part of the big response is working. It is doing some of what it's supposed to do. And that gives public health the confidence to say, that's one of 5 things that we have available. To go back to the purpose of public health, you know, we're telling people, here's the 5 things that we know you can do right now for COVID. Get vaccinated, social distance, wear your mask, wash your hands, and sanitize. So we've still got those 5 tools, and we're constantly looking to see, are those 5 tools helping? Because that's all we've got right now. Okay, Becca, do you have just a little bit more? And then I think that there's a lot of questions, so we want to give some time for these folks to ask questions.
Yep. So we have race and ethnicity here, and you can again hover and then deselect and select. We have our tests by week and then our test positivity rates by week. And you can see how our test positivity has gone up through Omicron. This is our testing sites, and there are no testing sites. I got to fix that. So apparently there's supposed to be little pins in there. So I'll fix that tomorrow morning. And then this is
side note, Becca, I think I sent you an email today about a change on one of those testing sites.
I think it was Missouri. They canceled theirs.
The Missouri one. You're right. It was the Missouri one.
Because it was cold. Yeah, it's good. So then this last map is a map of population. So yeah, and then deaths by month compared to 2020 to 2021. And you could see in December of 21, we had 33 deaths. In December of 20, we had 120. So you can again see how vaccination has really kept the deaths to a minimum. Yeah. So that's the dashboard.
Yeah, thank you, Becca. And Amy?
You're welcome. So now we'll take questions, and we just had one through the chat that I answered, and it's a question we often get, and that's, are we tracking the vaccinated versus unvaccinated? We have access to some of that information, but we don't get all of that. So if it's a hospitalization or a death, the hospitals report those to IDPH. Not to us. So we get hospital numbers every day, but and Becca and I get the same hospital numbers that Tony gets. And they don't have they don't have the vaccination status. They just tell us, like, how many current COVID patients do they have? How many are in ICU? What's the ICU capacity at the hospital? What's the overall bed availability at the hospital? We get that kind of information, but the hospitals don't give us that information directly about their vaccination status, but they do report that kind of information to IDPH. As far as deaths go, deaths come from all different places. So we get all of the death information, but sometimes it comes in slow and it comes from all over. Sometimes we get it from the hospitals. Sometimes we get it from the coroner's offices. Sometimes we get it through IDPH. There's a couple different funnels at IDPH we can get it through. IDPH's Vital Statistics Department is who gets it from out of state. So if you're a Madison County resident who dies out of state, even in Missouri, from COVID, that information goes through IDPH's Vital Statistics Department. Then it goes over to the COVID department to eventually get to the local health departments. And if you've noticed, there's been 2 or 3 times through the response where we've had to put like 26 deaths in one day kind of thing. and we noted that that was a catch-up day. That's because sometimes, I mean, we're constantly cleaning data. As a field, this has been extremely challenging and somewhat frustrating to try to give people real-time data, because in public health, that's not how it works. We collect raw data and then we constantly clean it to pull out duplicates, to pull out people that maybe they sent it to Madison County, Illinois, but it was supposed to go to Madison County, Indiana. Like, so that's sometimes how numbers change too. The other week, we had to take 4 people out of one of the age groups and had no idea anybody was actually looking that closely at ages. Someone messaged us and said, hey, why did I think it was the 60s or the 70s, lose 4 people out of that age group this week? Well, it's because we did some data cleaning and someone along the line, whether it was at our department or at IDPH or at a testing site or wherever, entered the wrong age for the person, for 4 people. So then we got the correct ages. And so those were all reflected, and we're constantly having to adjust things to that. It's just, nobody's ever seen that it takes a lot to clean data on the backside, and people are seeing it on the front end and don't really understand it. And then they think it's shady, but it's not. We're very thorough, maybe even more thorough than tax people with what we do with data, because these are people's lives and there's a lot at stake and there's a lot of things that are important. And we're extremely anal about this kind of stuff at our department, making sure that it's right. Our nurses are very diligent, and we have 2 different people that review all the deaths that come through to ensure that they meet the case definition for a death. And before we ever even report it as a death. So IDPH does collect some of that vaccinated and unvaccinated data, and what they do collect, they put on their website. So when people ask, I point them to IDPH's COVID site to find that information, because they're the ones that are really getting a majority of that, not us. It would be nice if we did, because 1 million people ask us for it every single week, but we don't have it, or we gladly put it out. So, you want me to do the questions in the box first, Carol? Is that what you want me to do? I'm going to take
Yes,
yes. Okay. At the Madison County Health Board meeting yesterday, a nurse reported that she had 5 patients to care for and 4 had been vaccinated. This seems to be an atypical situation. I don't know that that's atypical. People can get COVID if they've been vaccinated, and we've heard that. Omicron is actually able to get through the initial fully vaccinated, whether it was the 1-dose J&J or the 2-dose of Pfizer or Moderna. They are able to get through that. However, that's why we've encouraged people to also get their booster, because the booster seems to add the layer of extra protection that you need against Omicron. And so as an initial assessment, we think that's where some of these hospitalized patients are coming from, is they may be fully vaccinated, which means they had their original series, but they may not have been boosted yet. And anecdotally from the hospitals, that seems to be what we're hearing, because that nurse may have just, I wasn't on the meeting last night because I'm obviously here at home visiting family, but that nurse may have just known their vaccination status, but may not have, that wouldn't indicate whether or not they had the booster. And if you've got other, some comorbidities and some, especially autoimmune diseases, will make the vaccine not as fully effective in the person. I have a very good friend and colleague who has 2 autoimmune diseases, and her doctor cleared her to get the vaccines, and she has had all 3 vaccines, but she's also had COVID, even though her and her husband are super careful. Because her immune system is so compromised, and those vaccines are probably what saved her, that her COVID was mild enough that she could stay home and she got through it in a few days. If she wouldn't have had the 2 shots and the booster, she would have definitely been hospitalized and in jeopardy of mortality, just because I know what her autoimmune diseases are. So having those boosters for her, and that's why it's important for other people to be protected, because she intentionally hardly goes anywhere, and she's in her 30s, because she doesn't want to get sick, because she's got 2 young kids and doesn't want to get sick and die and leave them. So she gets very frustrated when people are being selfish. You know, she doesn't mind people making their own decisions, but when they say that they don't have to do it for other people, that's when it bothers her, because she's the kind of person that would do anything for somebody else to help them out. And for her, it kind of chains her in. But she does what she can. I mean, she respects that people can do what they want, but it does really limit people like her that even with 3 layers of protection there and hand washing and social distancing and double masking, she still is at high risk just by the nature of her disease. So I don't know who that nurse was or what they said, but I think that I sometimes think it's difficult and challenging for people to put a generality out there and make it sound like it's universal, especially if they don't have all that information, you know, in that kind of a situation. But I wasn't there, so I don't know. I just know that
I can say something about that. Nurse was up there basically complaining and thinking she shouldn't be required to get vaccinated. She shouldn't be required to disclose her vaccination status. So the woman who disclosed that information had an agenda.
Okay.
I don't think she was talking about every day. There were a lot of people trying to impute that vaccinated people were getting sick. Some of the claims were wild. There were claims that vaccinated people were getting more sick than unvaccinated people. It was bizarre. And I would like to ask you at some point if you could respond to how you respond to the quantity of disinformation and misinformation that is out there. It has been very evident in the last 3 board meetings I have attended. I do not believe that the current county board, the majority of them have the public health best interests in mind, and I'll mute myself.
It's very challenging to have to, I was at those, I wasn't at last night's meeting, but I was at the other 2, and so was Becca. It's very challenging to sit there for me, Tony, Becca, to sit in that kind of a meeting and not be allowed to say a word. It's hard. It's hard to sit and listen to so much misinformation, and we are the experts. This is our field. All of us went through a lot of years of education and spent a lot of money getting education from the top schools in the country. My undergrad's from Penn State and my master's degree is in public health from St. Louis University. And Becca right now is in a master's program online at Johns Hopkins University. You know, so we're not playing around here. We've got very well-educated and well-trained people. Tony's been in the field well over 30 years. I've been in the field over 26 years. And it's challenging, not just in a board meeting like that, but anywhere that we are, it's been a real challenge to constantly hear people tell us that we're wrong or that we don't know what we're talking about. We should do our own research. I've told people that, and I'm like, or people have said that to me, and I'm just like, I would never say that to my hairdresser or my mechanic or my surgeon, you know, or my tax man, or, you know, that's, my dad taught me that everybody's got a profession, everybody's got a skill and an area of expertise, and you need to respect that and stay out of their way and let them do their job. And so it's hard for me because that's not how I was raised, but I also try to look at through the lens that people through this whole time have been scared and unsure, and it's been unfamiliar. And when people are backed against the wall, when humans, my undergrad degree was in human development and family studies. And so when humans are backed up against the wall with something, we are animals in the end. And we search for an answer or a reason or an end or a solution or a way out or whatever, or a leader. And we will sometimes follow anything, especially if we have it in our mind that there's a certain answer we want or we're looking for. We try to find people that agree with us instead of being objective to try to hear what the situation really is. So think about your kids when they used to fight when they were kids. You know, they would try to find a way to get your attention or win your side or get you to agree with them instead of saying, well, let's talk about this. So when mom or dad say, let's look at the situation. What happened? What do you see that happened? What do you see that happened? What do you suggest we do about it? What do you suggest we do about it? That's not what's going on. People, for some reason, all of a sudden, you know, I'm like, you don't even know how to spell epidemiology. So why do you think that you are questioning our numbers and what we do? You just heard Becca, and that's like a very small smidgen. I don't know how many times she started to explain something to me or Tony, and we're like, sounds good, see you, bye, go do it, sounds great, because we trust her. We know that she knows what she's doing. And so we're paying her to do a job, and she's doing a great job at it. So go do it. And it's hard to understand when people think that, I don't know how many times Becca and I've been told through this response, they think the health department's making up data. Are you kidding me? We didn't have time to pee for those first year and a half. I mean, literally, I had a friend that the first 4 to 6 months, he would text me every day. Have you eaten yet today? What did you eat? How many times did you pee today? How many glasses of water did you drink? I'm not kidding. He texted me every day for months because he was worried, because he knew I was not standing up. I would fall. I was working from my kitchen table, and there were a few times where I stood up from my chair and I had sat there for so many hours, my hip gave out and I fell to the kitchen floor. So when people are like, you don't know what you're talking about, you're wrong, you're making up the data, it's honestly, it's personally and professionally crushing to me, because of how much time, effort, and heart I've put into this response into this county. And it often feels very disrespectful and ungrateful for everything we've done. And that's just me personally. I shouldn't even be saying that on the clock, but I am. Because I know that we all feel that way in our department. It's hard. I cannot tell you how many people have cussed us out, given us death threats, called us all kinds of things. It's been, I'm about to cry because it's been really awful. It's been absolutely awful. And then whenever you add on the misinformation that circulates in the community, that circulates in the county, things that end up being counter in your own county with what you're trying to do, things that are out there nationally, and then people just feel like they are empowered and they know all kinds of stuff. It's made our job in public information almost impossible, because I will say that the media has been probably our best supporters in all of this. Our media in the bi-state's been absolutely phenomenal. They have truly worked with us very closely to get the information out in a timely, accurate manner, which is our responsibility and theirs. And they feel bad for what we've been through because they've seen it firsthand. And when people couldn't get through to us, they were calling them, to the point that we could compare notes on some people. And they've done a great job of trying to help us dispel those myths. And if people have been watching, you know, your local media sources, they've been, that information is coming directly from me 99% of the time. Tony does it when I'm gone, I'm on vacation, but that information is stuff that us as the leadership team, me, Tony, Becca, all those directors I talked about, and then 2 other staff who play a vital role in the response, we come up with that messaging together. And we look at data, we look at behavioral trends, we listen to what people are saying on our social media, good and bad, because that helps us to figure out, like Becca said earlier with the data, that helps us to know what the behaviors are. It helps us to know, what are you scared of? Who are you listening to? What do you really want to know? And that helps us craft messaging to get out there. But sometimes we're also limited on the messaging that we can get out there. And that's something else that we don't have control over either. And there's a lot of factors that go into that as well. And that's a whole different challenge in the misinformation piece. You know, all we can do is be the soldiers to stand here and stay, you know, true to our ground. Tony always says, you know, you have to do the best you can all day long, and go to bed at night, put your head on your pillow, and know that you did the best you could with what you had for the people we're here to serve. And they're going to think what they want to think. They're going to do what they want to do, but we still did what we committed to do. In our master's programs in public health, we take a covenant, or at least I did at St. Louis University. Before they hooded us with our masters, we had to take a covenant that had all of these different pieces in the covenant about serving and protecting and providing and doing our due diligence. Just like a doctor takes an oath, we have to take a covenant. And I don't think people really realize how deep and professional public health really is, and that particular aspect of caring and protection that we all take on, and we feel very responsible for. I mean, our clerks, even at our department, our secretaries, they all feel that same level of responsibility to the community. And I just wish the community actually knew that and understood that, because I'm going to go back to, there's currently 46 of us and 265,000 residents that we're trying to serve every day. Let me see what other questions we have.
The one thing I want to add though is I think social media is amazing and it has great things and it's been helpful so much in this response, but it's also been really harmful at the same time because of how quickly information gets out there. It's great whenever like accurate and truthful information gets out there, but it's really difficult to combat when misinformation and disinformation gets out there, because it's so difficult to combat that because it spreads so rapidly. And there's not much that we can do about it other than try to dispel the myths. And how are you going to make sure that you reach everyone that you can? And that's
to
what's
convince someone that a nocovid.com is not a valuable, not a viable public health resource to get your research from. I mean, we've had that level of it, and we're like, boy.
At Johns Hopkins, they had
a public health. You don't know where to look.
At Johns Hopkins, they had a graphic that they posted on social media, and it said something along the lines of like, here at Johns Hopkins, we believe in peer-reviewed journals. So that's one big thing that you should look for whenever you're looking at information is peer-reviewed journals, and you know, your local health department, the CDC, FDA, WHO, those actual government officials, they will be helpful for you to figure out if you need any information, especially the CDC, IDPH, and our website regarding COVID information.
Okay, next question. Do deaths from COVID mean COVID was the primary cause of death, or does it mean that COVID was present and may be not the primary cause? Let's stop there and do that. Becca and I actually talked to the coroner's office about this, what, 2 months ago now, maybe, that long conversation we had with Kelly. In order to certify a death as COVID, they've got a whole checklist, any of them, whether it's a physician at a hospital or the coroner's office or whoever, they've got a checklist that they have to meet certain criteria to call it a COVID death. And he said that it's kind of in between the two things you wrote. It's not always an either or. It's that COVID was a primary contributing factor to that death. So, you know, they may have died of, I don't know, COVID pneumonia, but it was the COVID that caused that pneumonia that contributed to that death. So all these rumors that people are just, yes, there was like 2 states that at the very beginning for a hot 2 months before they were caught were cheating on the death things. Well, that got caught pretty quickly and cleaned up. Again, that's what the data scrubbing's for in public health. I'm sure it's someone that like, it was someone like a Becca in another government role caught that and it went up the chain and it got corrected pretty quickly because we've got a lot of checks and balances. But to be a COVID death, it has to meet certain criteria, and the people that can declare it a death and put it on a death certificate, they also take an oath. And they also have to meet certain criteria, and they also have regulations to follow. And I don't think people realize that they don't get to just write whatever they want on a death certificate. So if they cannot prove that it meets certain criteria, they can't put it on a death certificate. Now, some people are really mad that it ends up on a death certificate, but they can be mad all they want, but that doesn't mean it doesn't meet the criteria. You know, you can be mad all you want that you got an STD, but if you got it, you got it. Like, you got to face how you got it. You know, it's the same kind of thing. Lots of people don't want to take accountability for stuff, but that's how that works. And the coroner's office, I was glad he explained that to us because we'd gotten that question a lot and it was kind of challenging to write. I will say that all of the deaths that we report as COVID deaths in Madison County are all confirmed COVID deaths. There's a category called probable COVID deaths. Now, IDPH does report the confirmed COVID deaths and the probable COVID deaths. So the probable COVID deaths is that COVID was a probable factor in the death, but it was not able to be confirmed, or that the person is probable to have COVID, but their COVID status had not been confirmed. So those are considered a probable COVID death. In Madison County, the ones that you see out on our graphics and on the dashboard, every single one of those is a confirmed COVID death. They met all of the criteria that the regulations state to be a COVID death. So the state is reporting the probables and the confirmed. We're only reporting the confirmed. That's why sometimes people ask us, why does IDPH have more deaths listed than you do? That's why. And then they scrub some of those out and they move them to their probable death category. But our staff in reverse, that's why we have a nurse and an epidemiologist that are scrubbing through that data, the death data, before we get it. So we reported 3 deaths today, but that doesn't mean the people died today. That means that we assured today that those 3 deaths are confirmed COVID deaths. And we're double checking or assuring, if you go back to those 3 public health core functions I mentioned, we're assuring or double checking that the people that put the COVID death on that death certificate, that it met all the criteria it was supposed to. And then we're double checking that. And then we're saying, yes, we agree that was a COVID death. And then we put it out. Does that make sense? So they get to declare it, but we aren't going to tell the public about it if it doesn't match the criteria for us. Instead, we would call whoever that was that did that death certificate, that doctor or the coroner's officer, whoever, and our nurse or our epi would talk through with them. Hey, we don't quite understand this. This doesn't quite line up with with us. And they talk through it to see if they missed something or if we missed something. So we're even very diligent about what we're reporting as a death and how, and double checking each other. And I don't think the public really understands the depths at which we're really going over all of this stuff before it goes out. And then you ask, how do you respond to the crazy allegations that there have only been, I'm trying to do it without 50,000 deaths? I don't respond to that because that's just nonsense. People are doing the most, as Becca says on a regular basis to me. People are doing the most today. And I'm like, what's happening today? Because she monitors all the media for us too, internationally down to locally. And she'll be like, okay, here's the 5 big things right now. This is going on in the Ukraine, and this is what's happening in New York with COVID, and here's what is on the local news with us. She loves doing that part, and I don't. So I'm so grateful she likes doing that stuff. I don't respond to that. Public health officials have confirmed those deaths. So deaths are deaths. That number, I think we're over 800,000 now. My colleagues across the country have confirmed that, and I'm going to stand by them. And that's what I would tell someone if they really pushed. What kind of tools do you manage the COVID data with? Becca. I do the fancy graphics in Canva. She does the fancy stuff behind the scenes that I only know the kindergarten level of.
So I guess it depends on what kind of data you're looking at. So there's spatial data that I use, and I use like ArcGIS Pro and ArcGIS Online. And I also use Google Earth, depending on what I'm doing. So ArcGIS Pro and ArcGIS Online, it's software made by this company called Esri. And so they make a lot of spatial data. And so not spatial data, spatial software platforms. So what these platforms help me to do is to get data and then put in a spatial component, whether that be like a latitude and longitude, like a zip code, an address, anything like that. And I can go and look at this data kind of from a bird's eye view. So, whenever you look at Google Earth or you go and look at a map and you're looking from above. So what this data and what the software helps me to do is to look at aggregated data, or I can look at point data. So let's say for internal use, I'm looking at locations of STIs, and I could internally map the addresses of these people to see if there's clustering, if there's a lot of people in one area, one community that needs, maybe a health education program on STIs, or maybe a testing clinic or something like that. I can look at this data at a very small level and see, what kind of commonalities are there, what kind of linkages there are. But on the other hand, I can also aggregate this data and combine it all together so that you can't tell where these people live, who they are, any kind of identifying information. And so that's a lot of the maps and stuff that you guys see on your side. the aggregated data, so that way it's all de-identified. So
So
that's
we
what a
use the
lot of,
other stuff to help figure out where clusters might be or where we need stuff. Like she said earlier, where do we need vaccine clinics? Where do we need testing sites? Where are we having, pockets of outbreaks or clusters of people, and what are the behaviors in those communities look like, those kind of things.
yeah. So that's one part of it. And then you have the other part, which is like the front facing side, which is the dashboard. And so that's through Arcgis Online. And so they have like this dashboard function where it's kind of like drag and drop. You just create your dashboard. You have to make sure you have all of your tables and attribute tables, which are kind of like Excel sheets. And so you set up your attribute table, you put in all your data and information, you upload it, and then you create your dashboard. You could also use a code called Python to, make it do certain things that you want. I've also had to use, I don't know if any of you guys have looked at our COVID-19 hub. I created that also using Arcgis Online, and I also hand coded that. So almost every line of code that makes it front facing, everything that you see is a line of code that I wrote. So that code was used with CSS, JavaScript, and HTML, which is pretty much just like basic web paging code. I'm also gonna dabble in this thing called R-Shiny. And so I'm looking at creating certain dashboards of information with R-Shiny. And that's with this other code called R. And so that's kind of a statistical code that you can use to crunch numbers and everything. I'm still learning that, so I don't know if it'll pan out, but I'm learning. And I also use,
I'm sorry.
I think that's it.
That's enough. My son asked this question, and I know other people have other questions. He could talk to you for hours on this. Database.
I was just gonna say, the other thing I use is Excel. So that's it. That's it.
And I was just going to say the nurses have
say-
a few databases that are all tied into the state system, and they use those. So hospitals have to report things in a certain way. We share information with the state through certain. So there's all kinds of different. The contact tracers have a system called Salesforce they use. So we've got data all over the place that we're trying to pull together and keep up with. So there you go. Okay.
Well, I do appreciate it. We check the dashboard every day, and we check the Johns Hopkins ones at least 3 times a day. And so we do appreciate all the work that you do put into that, because it is helpful.
Well, if he ever wants to talk
Fascinating.
more about what Becca's doing, he's welcome to call her. You're welcome.
That's what I said. We'll get her email address.
Yeah, and my professors actually helped create that dashboard for Johns Hopkins. So
You said there's
if you're
some
ever
stuff from Brendan. Just
interested.
You can contact her
Okay.
later.
Becca, you can toss your email address there in the chat. Okay, the next question is from Ann Masters. What can you tell us about the 4th shot, the 2nd dose? I can't tell you much yet, except for that I know it's a possibility. As I said earlier, this is a new virus still. 2 years into a virus is extremely baby infancy. That's like having a 2-week-old in the public health world. We have a long way to go. We have a lot as a field to learn about this virus yet, and it will take years. So when you see mandates come out right now, none of those mandates are coming from public health. They're coming from government, and they're coming from corporations. This is way too early, probably at least a decade too early before public health as a field would mandate a vaccine, because there's so much we still need to learn about the virus, and there's so many additions we need to make to the vaccine or boosters that you'll need to get along the way. Since it's a new virus and we don't know what it's going to do or how it behaves, we have to continue to adjust. And that's just what science is. I just think there's a lot of people that didn't pay attention in freshman science class, is what I've told the reporters, that they're like, well, they must be lying because things keep changing. And I'm like, they must have failed freshman biology class, because, that's what science does. You continually make changes and make improvements to make things better. You do that in engineering, which is a science. You do that in the medical field, which is a science. You do that in public health, which is a science-based field. That's just how science works. So I don't know anything about if there's going to be another booster or when. I do know that there has begun talks through the ACIP coalition for a possible another booster, especially for the highly at risk, the immune compromised. I think, Becca, wasn't that specifically the immune compromised was who the initial conversation was about at the last meeting. Again, because of their weakened immune system, they need extra protection. But as we learn more about this virus, we'll probably need to keep doing this, or they'll reformulate it. Right now, it's the same formula still, because the boosters of the same formulation seem to be helping. So there's no sense in manufacturing a new formula yet. What I do know is Merck and Pfizer both have a pill in development, kind of in the mid-development stage right now. The Merck one looks like it's going to fizzle out and not make it. The Pfizer one's starting to show promise. It's not a preventative pill, it's a therapeutic that you would use once you are sick. And the idea of it is so that it would act kind of like Tamiflu. When you would start to show symptoms, you would take it and it would help decrease the severity and shorten the duration of the illness. So it's not going to be a preventative thing, but it sure would be a more helpful, probably shelf-ready therapeutic, because right now we have some therapeutics, but they have to be available from a doctor in a hospital, and you have to meet some fairly strict criteria to get some of them for reasons, a variety of reasons, depending on what the therapeutics are. And Dr. Weber, who is on our health advisory committee, any of the physicians really on our health advisory committee, they're very well versed in this, and they do a great job of explaining the therapeutic end of it, because that's not the public health side, that's the medical side of healthcare. But we're kind of hopeful for that to just, again, help empower the public to feel like they can do something if they are exposed, while we continue to look at, as a field, what else can we do to help prevent you from getting it? Let's see, next question. Oh, thank you so much. You have my empathy. My head would literally explode. Yes, my poor mother. And there's 3 miles of sidewalks in my subdivision. So I would often walk at night and just call mom and just, word vomit all over the place. And she would say, I love you, and hang in there. And do you feel better? And I'll go back home and get back at it. And it might have been 9 o'clock at night, but God love her. She listened a lot. Becca and I've talked to Becca more than any human on the planet for the last 2 years, no joke, nonstop. I drove to Pennsylvania the other day and we were on the phone for probably 5 hours on and off, no joke. It was crazy. It's weird. I hadn't heard her voice in the last 2 days, so I called her this afternoon because I thought something was wrong. So yeah, we appreciate the support. Thank you so much. What else can you do to help? Just continue to help dispel that misinformation that's out there, and encourage people to listen to the public health department, and maybe, help us tell the public health story, because a lot of people don't know about it. And as public health professionals, we're not good at tooting our own horn. We're not good at telling our story. We're good at just kind of putting nose to the grindstone and taking one for the team and doing what has to be done. So that's a huge help, and just, continue to enforce. That's the one thing the media has said to me multiple times is, wow, your message is consistent. Your information doesn't change very often. And I'm like, yes, because this is a public health emergency and we're the lead and we're telling you this is what it is. So our stuff's not going to change until the science changes, and it needs to. So
I have a question from another health area.
sure.
What is the situation with lead water pipe in Madison County? What towns have a problem? Lead water pipes.
That's a great question, and I don't know. I would suggest starting with Erin Baster. She's our director of health protection in the county, and she would be a great person to start with. And if it's not her, she probably knows who to talk to. If you call 618-296-6071, that'll get you directly to Erin's voicemail. Let her know that you were on this meeting with me tonight and that you had that question and that I sent you to her.
The phone number again?
618-296-6071. And her name's Erin, E-R-I-N. And if she doesn't know, she probably knows who does.
Thank you.
You're welcome.
Okay, we are approaching 9 o'clock or 10 o'clock where you are, Amy. So
Yeah,
if are there any other questions?
I guess
Um,
I'll submit one more. If anyone has a radon test in the county, do you get any record from companies who sell those tests as to our situation in Madison County?
I don't think we get a report of the actual test, but Erin, the same person, she's the one that radon's always kind of been her thing at the office. So she's kind of got a big heart for the radon piece. And the air quality stuff is the other piece that she has done a lot with. So she would be able to tell you. I know that she's got an idea of the amount of radon in the county and kind of the hot spots for radon, but I don't think she receives direct reports about radon, but I could be wrong. She may receive those and then I just don't know about it because that's not anything that I need to know. But yeah, so that was the same person that asked that question, correct? The one about the pipes and the radon, right? Robert Frank, you asked
Yes,
both of
thank
those?
you.
Yeah,
Thank you.
so whenever you talk to Erin, you can ask her about both of those. And then someone in here also asked about, is there a process for seeking an increased millage for the health tax? That's a decision by the county board to increase that. And they do it in kind of a strange way to me. Any department in the county that gets a special tax fund, instead of them being individual on the slide gauge like ours to increase it, they put all of us in a pie. So if they increase ours, the way they have it set up, they decrease someone else's. And none of the other departments what there's decreased, which I don't understand that when the base tax of ours is based on a millage of its own, that's the slide that you could go up to a certain amount. So I don't, that's a piece I don't know enough about why the county does that or can do it that way. But that's why we've never sought an increase in the millage, is because, well, we have kind of sought it. We've asked for it and they've told us no, because they don't want to take money away from a different department. But why it's in a pie like that, I don't know. That's a good question for the financial committee for the Madison County government.
Yeah, I asked that question, and it seems to me that if there was a previous tax that they had arranged, you should be able to go up in there. And I think part of this is they want to keep taxes low, but of all the departments that do the most for county residents, it seems to make sense that, you know, yours is right up there with the police and other things. Again, there seems to be a conflict with protecting the public health, safety, and welfare, and they just don't seem to be, they keep pulling out of that. So
I understand it.
Okay.
So those recovery funds, the COVID recovery funds that came from the federal government, so they're coming in 2 or 3 installations. I don't know, a lot of you probably saw the first couple $1 million we got and how it was divided out. None of that money went to the health department. And so that's just something, you know, since you guys seem to be interested in that, to just kind of watch and keep an eye on. And if you've got a concern or something, always talk to your county board member and encourage, you know, let them know what your concerns are and funding, because it's stuff that we have no control over. They don't ask us about that kind of thing. You know, we submit our annual budget every year. Our budget process is July through usually September. By the time we submit the first round and we go through several drafts, and the fiscal year starts December 1st. But, you know, a big fund like that, that's nothing that the county administration goes through us. I mean, because they don't have to. But all of that COVID recovery money and community development received a huge amount as well. They did use a little bit of theirs to help us last year. We were having trouble reaching some of the shut-ins and some of the homeless and some of the senior citizens. And so we worked together with community development. It was actually their idea. They came up with the need, especially with the vaccination piece of it. And they paid to make sure that a lot of seniors in the county, especially those that get Meals on Wheels delivered or homeless or shut-ins, they were a huge help to us to try to reach those populations with not just information, but with context of who it is, because we set up with the EMS services across the county that either us as health department, our health department nurses, or our EMS services we had to gather from all the municipalities and through the senior network and community development help to gather all of that information so that Becca and I just didn't have time to gather it. Lisa Mersinger was just a godsend in all of this. They helped give us a huge database that then we were able to feed into our nurses and our EMS in the county who agreed to go. They actually drove to people's houses that were shut-ins or unavailable. They were not available to get out to get a vaccine, but they wanted one. And we went physically to people's homes to give them vaccines to make sure that everybody who wanted one could get one. And we did what we could. And we still hear every once in a while of a situation like that. And at this point, we usually send out one of our nurses or we call the EMS system that helped and say, hey, is this person in your jurisdiction? Can you guys get out and get them, get them on the vaccine? So even now we still get that call every once in a while.
Okay, I'm going to call time because it's approaching closer now to 9 o'clock here. And you were both very delightful speakers, and thank you for spending almost 2 hours with us and very informative. And
Well, thank you. Thank you so much for having us. And thank you for being interested in public health, because Becca and I always love it when people want to listen to us talk about something that we obviously love very much. And I am going to make an announcement just in all fairness and disclosure so that you know. The reason why I'm in Pennsylvania visiting my family is because I am moving to Texas in a few weeks. My last day at Madison County after 21 years is February 1st. I've accepted the position as the director of the Bell County Public Health District in Temple, Texas, which is where Fort Hood is. It's about an hour from Austin. My high school best friend and her husband were in the Army and they retired there. She happened to see that their health director resigned last May, and last July they announced the job, and she said, hey, just apply for it. I'm like, I'm responding to a global pandemic. I'm not looking for a new job. She's like, just put it in. We haven't lived in the same state since we were 22. Who cares? Let's just see what happens. And I did. And it's been a long process, but I ended up getting the job. And I have a strong faith, and it's just all kind of fallen into place, and all these doors have opened up tremendously. And so I'm very sad to leave Madison County and everything I've built here and the heart put into this place, but hopefully I built a good legacy. Texas, these folks are very kind, very excited. The background that I have is the same pieces that they are looking for. And they know as a department, those are pieces that they need, and they just have never been able to find someone to do it. And they can't believe I'm willing to come to Texas and help them. I kind of can't believe I'm coming to Texas to help them. But having, Melanie and I have been friends since we were 14. I'm going to live with them while I have a house built. And we have a couple other friends in the area too that they were in the military with that retired there. So I'm going to have a small support network to start with. And I'm a little scared, but I'm really excited for this new challenge. Fort Hood is there. The SpaceX program headquarters are now there. Tesla, Microsoft, and Amazon have moved their California headquarters there. And we've heard rumors that Disney and Amazon are buying land to put something there too. So I agreed to do the job before I knew all of that. So I think I got an even bigger job ahead of me than I thought. But I've wanted to run a department and be the director like Tony for a long time. And we always just thought that I would take over this department when she retires. But I guess that there's a bigger plan than either of us had. And she's very excited and very supportive of me. And so I really appreciate everything that she's done in support of me. And I feel bad because I want to pack up, the people at my department and my little home and my great neighbors and neighborhood and take them with me. But for some reason, they can't all come to Texas with me. But I tried, didn't I, Becca? Tony's like, don't be stealing my employees. So I wanted to let you guys know that, but Becca's still going to be there. But I'm going to be in Texas and going to have a lot of work ahead of me. I know, right? I'm in the middle of a global pandemic response, but let's just go ahead and move to Texas and start a whole new thing with a new department too. Because, I don't have enough going on, but that's okay. I like a challenge. It'll be great.
yes, it will. Best wishes for you, for your new position.
Thank
And
you.
it'll be warmer down there too.
That's what everybody says, but my mom got 15 inches of snow on Monday, and I had so much fun out there shoveling in the grass for the dog to have a place to go because he's a Shih Tzu and he's not 15 inches tall. And he hadn't gone to the bathroom in like a day because he couldn't go anywhere. So I shoveled for him yesterday, and And I love it. And my best friend that lives there said that's what a plane ticket to see your mom is for. Don't bring the snow to Texas with you. So I'm going to try not to.
Um, Becky, is there anything else that you would like to say?
No, we're good.
All right. Well, thank you so much for spending your 2 hours of your vacation and your evening with us.